So good evening. Yes, I'm Adrian Windsor. I'm a board member emeritus. And yes, I've been with Medicine in Our Backyard since its inception. And curiously enough, that was at the Herbert Gavin Center. And we were discussing with Mike and Polly Smith what we could do to bring UCI's faculty to the library to enrich the community. And they became supporters of this program, and they've supported it ever since. So this is a great partnership between the Newport Beach Library Foundation and UCI Health. So we're happy to have you here. We love it if you come every month, and each time we address a new health challenge. So a bit about us. The Library Foundation is not only, as Jerry said, involved in this construction because the foundation agreed to raise half of the money to pay for that lecture hall, even though it will belong to the city. And so Jerry has been the head of that and has done a remarkable job. And we have another, I think, 16 months to finish the fundraising. And as co-chair of development, they just put Beyond Books under development, so now I'm co-chair of that. So if you have any interest in Whitty Hall, in supporting it, call Jerry or come by and see him. We would love to have you be contributors. Now, the foundation also contributes many different things to the library, like the media center, the chairs you're sitting on. But we have two very distinguished programs as well, and the Whitty series and the Library Live. And I just wanted to bring to your attention that on October 4th, that would be a week from Friday, Jerry just reminded me it's on a Friday, Bonnie Garmus is coming to speak to us, and she wanted an audience of 500, so we are holding it on the Civic Center green outside, and we will have 500 people there. She's the best-selling author of Lessons in Chemistry. Some of you may have watched it on Apple TV. It was even, I think, nominated for an Emmy. So this is a real opportunity. We hope you'll join us for that. Now, a few reminders for it. Q&A comes after the speaker, and please don't ask questions while he's presenting to us. And also, if you could be sure when you ask your questions, you only ask a question and don't give us your whole medical history, because it makes the program go on very long and our speaker will want to go home. So, and also remember to silence your phones. So I'm pleased to introduce our speaker, Dr. Soroosh Behshad. He's going to be speaking to us about seeing clearly, what you need to know about cataract surgery. How many of you have had cataract surgery? And how many of you have been told you need cataract surgery? All right, good. That gives you an indication of your audience, Dr. Behshad. So Dr. Behshad is a board-certified UCI Health ophthalmologist who specializes in cornea, cataract, and refractive surgery, and an associate professor in the Department of Ophthalmology, ophthalmologist, UCI Health. He earned his medical degree at the University of Arizona College of Medicine in Tucson. He completed a residency in ophthalmology at Tulane, and he also was chief resident there, followed by a fellowship training in cornea, refractive, and anterior segment surgery at UCI School of Medicine. Now, the remarkable thing about him was after several years, UCI brought him back on the faculty where he is now an associate professor. So we know that he has remarkable credentials. So please join me in welcoming Dr. Soroosh Behshad.
Thank you so much for that introduction. And thank you everybody for joining us tonight. This is a topic I am very passionate about when it comes to anything related to the eye. Cataract surgery is up there. So I added a little bit to the topic, and that's seeing clearly what you need to know about cataract surgery and a little more. So at the end, I'm going to bring in dry eye just because that's something that's very important, not only when it comes to when you're considering cataract surgery, but being here in Southern California. So thank you again for the warm welcome and for inviting me here. Great to see familiar faces, new faces, and looking forward to carrying on the discussion with the question and answer after. So I just everyone always thinks like I'm the new guy, I just showed up, but I actually completed my fellowship here at UCI in 2015. And I took on a position at Emory University in Atlanta for 7 years, where I was very involved with training of residents and fellows there. My wife wanted to be closer to our family, so the stars aligned when I could be back, and they wanted me to come back. And so we're happy to be back. I've been back for a little over a year here at UCI. And so one thing, that's very important for me when I'm meeting my patients is I kind of want to know what their story is, what their career is, and why they do what they do. And I think one question I'm commonly asked is, why ophthalmology? And for me, I feel very lucky that as an undergrad student, I got to shadow some ophthalmology residents, and I was like, this is amazing. You get to work in clinic and follow patients and see their journey, and then go into the operating room and do surgeries. And, people the next day, you can see the impact you're making. And for me, my interest also is in global health and global ophthalmology. And that's something I feel like you can do with any field in ophthalmology, in medicine, but with ophthalmology in particular, we can go somewhere and actually have an impact on the global stage and also increase the capacity. So that's another thing also, not the topic for this evening, but myself and many other faculty members at UCI do a lot of global blindness prevention. And so that's something, if you're interested in, I suggest getting on our email listserv so you can learn more and find out ways that you can get involved as well. All right, so that's the boring stuff. Let's get on to the interesting stuff. What are we going to talk about tonight? So we're going to talk about what a cataract is, how a cataract forms, what the impact is for the population that's above 65 years of age. Also, when it comes to things of how do cataracts impact driving, why do we care about that? What's involved with a preoperative evaluation for cataract surgery? What can we expect? And then what's involved with the surgery? And I have a lot of surgical videos here, so I'll try to give you guys some warning. If you're kind of squeamish about eye surgery, I'll give you a heads up. But just to kind of show you that the surgeries are very minimally invasive and the recovery is pretty quick and easy. We'll also talk about potential complications, what can happen, what you should be, considering. What is this thing that maybe some of your friends have talked about, like the cataract coming back, or a secondary cataract, or a posterior capsular opacification after cataract surgery? And then lastly, kind of tying in dry eye and why do we care when it comes to cataract surgery. So very briefly here, kind of to give some idea, real estate of what we're working with. The eye, we can see here, my favorite part of the eye is the cornea, which is the clear part here. And so when you're looking at someone's eye, you're actually looking through their cornea, and then the pupils just behind that. And the cornea is involved with about 2/3 of the focusing power of the eye. So it is the focusing power house of the eye. Behind the pupil, we have this structure here that is the lens. And so when we're born, that lens is very soft, liquidy, jelly, and we have some muscles that can kind of change the shape of that lens and help us with accommodation. And so that's why when we're younger, we kind of can read up close easily. And as we mature and get more educated, we have to move things out further and further. That's kind of the cataract forming. And then behind the lens is the vitreous cavity. And so this is actually not liquid, it's jelly. And this is involved with something I think all of us have experienced or will experience, and that's floaters. So the jelly within the eye, as time goes on and the eye normally matures, we can get little protein deposits in there that cause those new friends we have that kind of move back and forth. And then lastly, we have the retina, which is the lining of the posterior aspect of the eye. And that's where images are focused on, and the image is turned into a neuro signal, and via the optic nerve kind of sent to the brain, and that's how we basically see. Obviously we're not going to cover diseases of the optic nerve or the retina, but those are real important areas that, for future topics that we can kind of consider to talk about. So that being said, a common complaint of patients that come to see me is, Doc, I'm here to have my cataract removed. So if you don't walk away from anything, please just remember it's a cataract. It's not a Cadillac. We're not removing a car from your eye. And so here, kind of just focusing in on the lens that we were talking about. The cataract formation is a normal age-related change of that lens, but you can have all different types of cataracts, and there's even congenital cataracts. So babies can be born with cataracts. People can develop cataracts at a young age. It can also be a side effect to various medications, and we'll talk about that. But, kind of the bread and butter age-related cataract is more nuclear. So if we look at the lens kind of like a peanut M&M, it's like that central peanut. It gets hard, yellow, and affects our vision. But we can also get a cataract forming in the back center. That's a posterior subcapsular cataract. Those are cataracts that move relatively quickly, and even week to week patients can notice a difference in their vision. So we'll kind of delve into this a little deeper here. So like we just mentioned, a cataract is the normal age-related opacification of the crystalline lens of the eye. And this process actually starts at 40 years of age, and very slowly it continues to progress. At UCI, we actually have high-definition imaging where we can determine the dysfunctional lens index. So basically, in addition to your vision, we can actually see how much the cataract is impacting your quality of vision. And so that's something that continues to progress as time goes on. For the vast majority of cataracts, 90% is age-related. We're all going to get this. It's going to happen. And the good news is outcomes are really good from cataract surgery. What are some potential risk factors? UV light. This is why it's important that we're, trying as much as possible to have UV protection. Systemic conditions like diabetes can cause a cataract to progress faster, or can cause specific types of cataracts. Any sort of trauma to the eyes can cause a cataract to form. And then there's a vast long list of medications that can cause cataracts to form a little bit quicker. Like I said, it's age-related, but for example, things like steroids, whether it's systemically through pills or eye drops, can cause that cataract that's already forming to form a little bit faster. So just kind of people always ask, like, how does a cataract affect my vision? So you can see here in this picture, there are two children with two balls. You can kind of make out that there's two kids, but the features of their face, the contrast, the colors are kind of blurred. And the thing we have to remember is cataracts is a slow process. It's not something where you wake up one day and you notice how much it's affecting your vision. So this is why it can creep up on the vision. So it's an overall decrease in contrast in colors. And just to show you some examples here, just in case you decide to change your profession at this point and want to go into ophthalmology, I'm pretty sure you guys would all diagnose this cataract as visually significant there. This is a hyper-mature cataract. I deal with this type of cataract all the time when I'm traveling in other countries. Believe it or not, here in Orange County, we do see this every once in a while, but it's a cataract in all the different layers of the lens. Very significant. All of you could pick that out. And then this one is a little bit more subtle. It's a posterior polar, so it's on the back center of the lens. So the rest of the lens is working fine, but there's almost like a little fingerprint in the vision. These can be very visually significant. And also there is a kind of a congenital connection with this. So people might be born with this. It doesn't affect their vision until later on in life. And there are some potential increased risks with the cataract surgery, which differentiates it from like an age-related cataract. So what are the symptoms with cataracts? It's not painful. It is a very slow blurring of vision. So that's difficulty with reading, distance, driving. And I would say with my patients, the number one symptom that brings them in is worsening glare, especially first showing up at nighttime. And so that can really affect the ability to do things safely. The other thing we kind of saw in that photo was decreased contrast sensitivity. So, colors and kind of crispness, those kinds of things continuing to progress and get worse. And as a cataract progresses early on, it just causes a change in the prescription. So we can continue to get new glasses and then the vision improves, but eventually it gets to the point where you're making the optical shop a lot of money and the vision actually gets to a point where it's not going to improve even with the glasses. And so at that point, definitely cataract surgery is a great option. Not something we see here in the United States, but if you don't have cataract surgery, if it gets really, really mature, it can turn into a very dark black, almost rock. And so that's something I've kind of dealt with outside of the US. But, at some point, you want to make sure you get that cataract surgery taken care of, because that makes it much more complicated, which none of you are going to get to that point. So the other importance here is, if we're talking about people over the age of 65, 1 out of 3 have some sort of visual loss. And so this affects our day-to-day activities. And we know with vision, it's very important with getting around safely, driving. And so that can impact our ability to be independent. And then, like every 7 seconds in the United States, someone falls and has an injury. And so a large part of those are due to, it can be due to inappropriate glasses, but it can be from vision as well. And so that's a big deal. If there's something that we can improve and keep us from having issues like falls and broken bones and broken hips. And then lastly, kind of all these put together, if we're losing our independence from driving, we can't get around safely. That can lead to other things outside of the eyes. That's, social isolation and also depression, just because that lack of independence is a huge part of our day-to-day. So all these are kind of factored into cataract surgery and why we consider it. And if we look at leading causes of vision loss in our mature, educated population, I don't know why it says elderly. These are the 4 things. We have age-related macular degeneration, glaucoma, cataracts, and diabetic retinopathy. And so obviously we're talking about cataracts tonight, but the reason I have it red here is because cataracts cause reversible vision loss, meaning we can get back the vision that we've lost to the cataract. With these other things like macular degeneration, that's an age-related change of the macula or the retina in the back of the eye. Glaucoma is an optic neuropathy of the optic nerve, and then diabetic retinopathy, changes to the vasculature of the back of the eye due to blood sugars if they're elevated. With those, we want to pick those up as early as possible and treat them, because any vision we lose, it's really hard to get it back. So that's kind of the difference. Cataracts, on that sense, is a great thing, just because not only can you get the vision back, but there's a good chance the quality of vision will actually improve after cataract surgery. So this is an actual public health issue. For every 100,000 miles driven, our older adults have a higher crash rate than the younger population. And I know we think the younger people are just, always on their cell phones and not paying attention, which is true. Distracted drivers is not safe. But we can see here when it comes to accidents and issues there, vision is number 1 when it comes to impairment with driving. Also, if we're looking at people over the age of 65, this is actually our fastest group of growing drivers. And then the other issue is that with this segment, an accident can lead to, a disabling condition and also potentially death. So we want to avoid car crashes in general, but if we're talking about 65 and above, the risk is already there. One thing for me, and many people don't believe me, but a lot of my patients, even though they're visually significant cataracts are getting in the way of their safe driving, drive all the way up to their cataract surgery. And it's that independence. We don't want to give that up. And if you don't believe me, this is a real life example of a patient of mine back in Atlanta who came to their pre-op visit to have their measurements for their cataract surgery. She was backing up her car in the parking garage and using her backup camera, and then wasn't able to see the curve and hit the gas and went over. And so eventually she did have the cataract surgery, but this was kind of a dramatic situation that now I have a photo that I can share. But it's real. And her vision is back, but she was a good driver up to that point. But these subtle kind of effects of contrast do make a big deal in terms of our day-to-day vision and also safe driving. Here in Southern California, we're relying on cars. We can't really get by without being able to drive. We've talked about the independence. We've talked about how losing that ability to drive can lead to, things like depression and feeling isolated, dependent on other people. None of us kind of want to be in that situation. And so this is where we have that kind of balanced approach. When the cataract is affecting our vision, we want to take care of it. We don't want to wait until we're at a situation where it's risky driving, whether it's nighttime or daytime. And kind of to demonstrate here what we're talking about when it comes to visual impairment from cataracts. So you can see here on the left, there's a car here, there's a girl crossing. Someone with a cataract who's got decreased contrast may not see that there's a child actually playing in the street and potentially hit the child, not on purpose. And then when we're talking about like halo and glares at night, so like here, these are some normal, I mean, you're going to get nighttime, you get a little bit of distortion around lights. Maybe you need a little bit of touching up on your glasses, or if you had LASIK like 20, 30 years ago, might need a little touch up. This is normal. But with a cataract, it can get to the point that the oncoming lights from traffic can just get in the way of the ability to see and get around safely. And then as we know, in the winter months, it gets darker sooner. So even though you may not be doing nighttime driving, it might be like 5:30 that it's dark outside, and this may be an issue to have to deal with. Obviously bringing up some research when it comes to this. I'm not just making this up, but patients who've had cataract surgery, their overall risk of having a car accident goes down by 50%. So I wish they gave us a discount from the car insurance company, but maybe if we continue this research, they'll honor that. But this is true. This is a big deal. So kind of moving on, what to expect if you or maybe a friend is going to be having a cataract visit to kind of evaluate them for cataract surgery. So your past medical history is very important. We do need to know what kind of surgeries you've had, what kind of medications you're on. Is it safe enough for us to do the surgery? And then also when it comes to the medications, knowing, with the type of cataract you have, is there any sort of correlation? And it's always nice if you've got a primary care doctor that can kind of help work with us to clear you if we decide to proceed with the cataract surgery. Having medical records is always helpful, but it's not possible. So we have kind of unique ways of figuring it out. So if you come in and you've got your glasses and your glasses are from 2 years ago, we can check your vision with those glasses, check the prescription, and see over the last 2 years what kind of change your cataracts have had. So that way we can adequately tell you, we've got some time, let's watch this, or no, we should probably do this cataract surgery in the next 6 months. Any sort of cataract pre-op visit should involve a full dilated and detailed eye exam. Like we talked about, there are potential risks when it comes to cataract surgery, but many of those things, if we can kind of know about them pre-op, we can lower any sort of bad outcomes after cataract surgery. More common in kind of congenital conditions or genetic conditions that run in families, or if someone's had a lot of trauma to their eye. And also something we'll kind of hit up near the end of this presentation is dry eye and how that kind of impacts this. We also, it's very important that we do high definition imaging because as part of cataract surgery, you'll see in a few slides, we remove the cataract, but we have to actually place a lens in the eye to help you focus. And so we want to make sure, because that lens is going to be customized to your eye, our measurements need to be really good quality and consistent. And I think the most important thing is patient education, what to expect. I think we'll hit over a lot of it, but I think this is an important conversation to have with your surgeon of what's involved with the surgery, what are the risks, and what to expect in the post-op healing. And then obviously this is an elective procedure, but you do need to give consent to have the procedure. So cataract surgery, believe it or not, 99% are done under topical anesthesia, meaning that patients are getting IV sedation. So you're relaxed, you get a medication for anxiety and a medication to relax you, but it's not risky. You're breathing on your own, and then your eye is numbed, and the surgery basically takes anywhere from 6 minutes to 15 minutes to do. Not common, but general anesthesia is always an option where we completely put our patients to sleep, do the surgery, and then wake them up. Obviously, anytime you're talking about general anesthesia, risks go up. And this is something we kind of reserve for, children or babies that have cataracts, or sometimes we have patients with dementia where they may not know where they are, and so doing it under IV sedation may not be a safe option. Or someone who has claustrophobia. These are all considerations for general anesthesia. It's possible, but we always try to proceed with IV sedation. And we talked about this is not a long procedure. It's pretty quick. And then when it comes to blood thinners, that's a common question that I'm asked. You don't technically need to stop blood thinners for cataract surgery. There are not a lot of blood vessels in the area that we are working in. Now, if you can hold them, your cardiologist or neurologist said it's okay and they clear you, it's always great, just because if you have a little bit of bleeding of the white of the eye, it takes a little bit longer for it to go if you're on a blood thinner versus if you're off it. So, but for the most part, we can safely do the surgery with patients on their blood thinners. So these are the overall steps of cataract surgery. And so everything is done through microscopic incisions. We make 2 microscopic incisions. One is less than 1 millimeter. The other one is about 2 millimeters. So you can see in this first the pointer's not working that great, so I'll just kind of identify which eye I'm talking about. So in the first one on the left, we're making our incision. And then the next step is the cataract is actually covered by a capsule. So we need to make a very small circular opening. So we have these fine microscopic forceps to make that circular opening. And then conventional cataract surgery is done with ultrasound. So we have a little microscopic handpiece that has ultrasound and then aspiration. And so basically we're liquefying the cataract very slowly, very carefully. And then after that's removed, then we switch to a different handpiece that doesn't have ultrasound. It just has a little gentle aspiration that we can remove the final layers of the cataract, which you can see there on the bottom left. And then we insert the intraocular lens into the eye, into the capsular bag. So that's what the cataract was in. So that way the lens becomes part of the eye and the eye heals to it and it becomes stable. And so that lens is kind of tacoed so it can go through that small incision and open in the eye. So that way we don't have to make a large incision. Back in the 1980s, the incisions were very large. And so that's what's kind of changed, where the recovery before patients would have cataract surgery, have to spend a week or 2 in the hospital, have lots of sutures. Nowadays, it's a quick in and out. No, for the most part, sutures aren't needed. And then just kind of showing you here in this last photo, that's kind of where the lens is sitting in the eye, where the lens we're born in was, or the cataract is. So the next video is going to be a surgical video. So if you are squeamish, maybe don't look at the screen, but just kind of showing you here, it's not that blood and guts as you think. So this is a very small incision there. And then, so the eye's been numbed, the patient's receiving anesthesia. You can see they're pretty relaxed. They don't even realize what's going on. That's just some numbing medication. The other thing is we need the eye to stay inflated during the surgery. So here I'm injecting a gel that we remove at the end, so that way the eye doesn't deflate and it stays fine. This is our 2 millimeter main incision where we're going to be removing the cataract from. And then the next step is using those microforceps to make that opening. It looks really easy, but you're in a really small space and you're trying as hard as possible to make that opening as circular as possible, just because that's basically like the surgeon's fingerprint on the surgery. So you can see here the vector forces there of just kind of bringing that around and making that circular opening. And then after this is done, you can see we have a nice circular opening to the cataract just with fluid, just kind of injecting some fluid around the cataract to free it so it's not sticking to the actual capsule and we're not traumatizing the eye. You can see here the cataract is moving in the capsule. And so it's kind of been softened that way. And then this is that ultrasound handpiece. So kind of the conventional way is a chopping technique where just taking the cataract and breaking it up like a pizza pie into a few pieces here. So now we've got 2 pieces, and then we're going to, now we're up to 3 pieces, removing one of those, going for the next. I think I might be losing a few of you from having cataract surgery by the face reactions I'm getting. So now half of the cataract's already out. This video is not sped up. So you can see just in a moment, we've removed half of it. Here's that 3rd piece here. And then the last quadrant is coming out. And so that's the meat of the cataract now is been removed. And now this is just some of the lining of that cataract. And then we switch to just the aspiration, so no more ultrasound after this. And this is just that last layer is almost like an onion layer here just coming off. And you can see it's being peeled off. So there's an actual capsule there, so we know that we haven't damaged anything in the eye. And it's stable that we can place a lens in that support system. And so just that remaining part of the cataract here, very gently peeled off. And just making sure there's no more of the cataract left behind. And you can kind of see the imprint of that circular opening, and that's basically what we're going to place the lens into. So here comes that lens. It's been folded up in like a taco. It's going through that 2 mm incision and going into that capsular bag where it's going to basically stay with the patient for the rest of their life and heal and stabilize. So there's 2 little arms that kind of come out and help stabilize it, and it's just a central optic. You can see how clear that is compared to the cataract when we started out. And so this is why the quality of vision actually improves after cataract surgery, just because we can provide high definition vision. All right. Is everybody feeling okay? So now moving on to the exciting topic, because when it comes time for your cataract surgery, you get to choose what type of lens you want. And so Medicare, insurance, they all cover cataract surgery. They cover a standard lens implant. And standard makes it sound like it's not good quality. It actually is. It's a good quality lens. It's just, what are you looking for? So with this lens, it has one focus point that we can give without glasses. So for example, we can set your vision for distance, but then you're going to need glasses for like computer screen and as things get closer. The other is you can flip it and set it for reading, but then you're going to need things for distance and maybe intermediate work. These lenses do not remove any quality from your vision, so you're not giving up any contrast. It's just kind of that, are you okay with needing glasses for maybe half to 2/3 of your stuff that you do on a day-to-day basis? Now, monovision is another option. That's where your dominant eye is set for distance and your non-dominant eye is set for kind of intermediate or up close. The only thing is you just want to make sure you've tried that and your brain likes it, because only half of people's brains like monovision. And after cataract surgery is not the time to try it out, because then you're stuck with it. So this is something, if you tried before in a contact lens, you've done well before, it's a good option. Now, moving on to what we call lifestyle intraocular lenses. The idea here is that we're decreasing your need on glasses. And so one thing with the standard lens, it also doesn't treat astigmatism. So there is an astigmatism correcting lens called a toric lens. So it's basically the same thing as the standard lens, but additionally treats the astigmatism. So people with high levels of astigmatism, that's an extra bonus. It's not covered by insurance though. And then our other options, we have multifocal lenses. So these lenses give you different focal points. So the latest one has 3 different focal points, one at distance, one at kind of the computer intermediate, and then a little bit closer than that. So not like reading this close, but you get 3 kind of distinct focal points. And for most people, they can kind of put their day-to-day in those focal points, and they do well without glasses. Now, the only thing with the multifocals, and I'll show you what they look like, is about 5 to 15%, that's a range there, of patients after the surgery do see a little bit of a clean halo around lights at night. And so that is something specific with the multifocal that you kind of have to decide, do I want to get these extra focus points, but potentially have some halo around lights? Most patients, it's not bothersome, but if you're an avid nighttime driver and you'd be bothered by that, might be a reason not to go with that lens. We also have an extended depth of focus lens. This lens splits light, so it gives you a good focus point at distance with a range to like intermediate. So this is good for someone that does a lot of computer and distance, not so much reading, because there's less focal points there, less chance for those halos around lights. And then the third option that we have listed here is a light adjustable. So this is like the greatest, latest technology that we have. I remember when I was a resident, like even my faculty were like waiting for this lens to come out because they'd been working on it since the 1980s. And hopefully my slides come back. But this lens we can basically place in the eye, and then after the surgery, we can actually adjust it. And so it allows our patients to be proactive in their ability to and so, for example, for someone who like they want to try monovision, but they're not 100% sure, with this lens, you can try it out, have an adjustment, and then if you like it, then it's locked in. So after the surgery, we can adjust the lens without having to do surgery in the operating room. So with a quick procedure in clinic with UV light, we can kind of change the shape. The caveat with this lens is that until we've locked that lens in place, anytime you're outdoors, you need to wear special UV protective glasses. They're fashionable, but it is something you just kind of, the chance that maybe there's a UV ray that comes from the sun that could cause some adjusting of that lens. Now, once the lens is locked in, no concerns, you can throw those glasses out. But with this lens, patients are super happy. The downside here is out-of-pocket cost. And then also the post-op kind of having to come back, try things until you're happy and having it locked in. So this is a video to kind of show you the normal eye. You can kind of see things far away, intermediate, and then up close cell phone. As we get older, we lose the ability to see up close. And then with cataracts, the overall decrease in contrast and colors. So with a standard monofocal lens, you can see things far away, crisp, but up close, intermediate, not as clear. With a multifocal, you're going to be able to see the phone, intermediate, and distance. And then showing here at night, the monofocal, not so much distortion at light, but with a multifocal, this could be the worst case scenario that you see a little bit of that halo around the lights. So just kind of trying to show you what these lenses can provide. And then just, for completeness sake, these multifocal lenses, microscopically, they have little rings. If you remember the surgical video, it was just one optic. And so this is how you get those multiple focus points by bending the light. And then the increased depth of focus just has a little plate in the center that kind of extends that distance focal point. Now, when it comes to the light adjustable lens or LAL, this is where, the ability to use UV light after the surgery and adjust the power of the lens. And, you can see here, it's a pretty easy tolerated procedure. It takes about 1 minute to 2 minutes max per eye to do that adjustment. And most patients, I'd say like 2-3 adjustments, they're happy, and then we can lock it in, and then they no longer need to wear the protective glasses. But overall, a great option also, not only for people that want monovision, but people that have had previous LASIK, because with this, we can actually treat some of the higher order aberrations from a cornea that has undergone any sort of previous refractive surgery like LASIK, PRK, and even RK. And so that being said, astigmatism, what is it? It has to do with the curvature of the cornea. This here is regular astigmatism here on the left. You can see it's a nice bow tie. So with this, we can treat very easily with an astigmatism correcting lens. And then we kind of go in the realm of irregular astigmatism, where the surface of the cornea is not perfectly regular. So that's something we want to address. There is a lens in particular for that. So people that, for example, might have keratoconus or previous RK, it's a small aperture lens. And so basically it's like a pinhole lens, usually goes in the non-dominant eye, that can kind of help make up for some of the irregularities of irregular astigmatism. But, this, like other lenses, there are some indications, and, you can't put this in both eyes. It's more your non-dominant eye. So more geared for someone that likes monovision. Now, moving on, we talked about conventional cataract surgery. We also now have laser cataract surgery. This has been around for close to 15 years, and it's where a laser does probably about half of the surgery before we even got started. So softening the lens, making the incision so we no longer have to use a blade, making the opening to the cataract, and also being able to treat the astigmatism. And here demonstrating to you, you remember that opening, that circular opening of the cataract that we did with the forceps? Here on the bottom right, these are man-made capsules. So yes, they're circular, but they're not perfectly round. If you look here at the left, the laser every single time makes a perfectly circular opening. And so that's a big deal when it comes to your vision. And so this is something, that many patients go for when it comes time for their cataract surgery. So once again, you get that perfectly circular opening. We can have to actually soften the cataract before we even started, so the surgery itself is less traumatic on the eye. Do some further adjustments of the astigmatism, and then make the incisions with the laser, so no longer needing a blade. And just showing you, this is a very quick procedure. This is the catalyst laser we have at UCI. And so, the patient's eye is, in a little apparatus, so it has gentle suction, so the eye is stable. And you can see in about 40 seconds, it's going to do the half of the cataract surgery. So already made the opening. Now it's softening the cataract, and then it's going to move on to an astigmatism adjustment and then make the incisions. After the laser part is done, then we proceed with the cataract surgery of removing the cataract. So, this is not covered by insurance. It's an extra out-of-pocket cost that can be packaged with cataract surgery. But here you're paying for a laser, that consistency of having that precision be part of your surgery. And that's the potential benefit of that. So now that we've kind of talked about the surgery, hopefully I didn't scare everybody. out of having it. Let's talk about what to expect post-op. So, shields, not everyone does that. I do that for all my patients. They go home from cataract surgery with a clear shield on their eye just to protect it. And then I request that they wear those shields at bedtime for 1 week. They don't have to wear it during the day, but it's just to kind of remind you that you had cataract surgery and you don't accidentally bump the eye. With cataract surgery, by a week, most of the healing from the surgery is done. We do have all our patients on antibiotic eye drops for 1 week after the surgery, and then there's anti-inflammatory drops that we taper over a few weeks. And so even though most of the healing is in that first week, we like to slowly take those drops off just to allow the eye to fully heal. In terms of restrictions, no heavy lifting, so no yoga or CrossFit, for that first week. No heavy lifting, really more than 10 to 15 pounds. The other thing is, it's okay to move your head. We just don't want your heart going below your waist, like bending over to pick something up. You either have to bend your knees or have somebody help you. That pressure increasing in your chest can come back on the eye and affect the incisions while they're healing during that first week. But reminder, that's only for the first week. And then for driving, that's really up to our patients. The anesthesia is in your system for about 24 hours, so we don't recommend any driving for 24 hours. After that, if you're feeling comfortable with your vision, it would be okay to drive. In terms of visits, we see our patients the next day, usually about 2 weeks and then a month later. In terms of eyes, for the most part, we do one eye at a time. And we won't do the second eye sooner than 1 week to allow that first eye to fully heal, for you to see that vision, be happy, and then move on with the second eye. So let's talk about outcomes. Success rate for cataract surgery, 97%. I mean, that's for any medical procedure is pretty amazing if you think about it. And cataract surgery is the number one done procedure in the United States. So over like 3.5 to 4 million people have cataract surgery a year. So to have success rates that high, it's pretty amazing. And in terms of risks for complications, so we talked about previous trauma, genetic conditions like corneal conditions like Fuchs. The other is infection. Thankfully, infection is not something we see often. You can see here in the literature, the rates are anywhere between 0.01% to 0.1%. And for the most part, this is something we've kind of mitigated with sterile technique and post-op antibiotics. But in infection, if it's caught early and we can treat it, the results can be very minimal, but if it's something that's kind of let go on for a week, 2 weeks, it can lead to some issues. And so these are pretty obvious. An infection after cataract surgery, the eye turns red, the vision starts getting blurry, the eye becomes painful. For the most part after cataract surgery, pain is very minimal, and the vision, every day continues to improve. It doesn't get more blurry. So these are things that you're kind of reminded if they happen to come in. But once again, luckily, this is not a common thing. Increase in intraocular pressure happens very commonly after cataract surgery. For the most part, it comes right down on its own. Sometimes we have to start an eye drop to lower the pressure to keep the pressures controlled, and then usually in the post-op period, then we can stop that. But that is common. The other is if someone's at risk for retinal tear, retinal detachment before surgery, that risk actually doesn't go down. It's still there. So it is important to continue having eye exams to just make sure there's no issues with your retina. And then a very common, it's not really a complication, but it's a posterior capsular pacification. And if you remember, with the cataract surgery, we're removing the cataract, but we're leaving the bag that the cataract was in. And so over time, your body heals to that lens, and you can get a little bit of the back of that lens sticking, or the back of that bag sticking to the lens, which creates some haziness. And so that's not the cataract coming back. It's just that membrane kind of starting to stick to the lens. And the great thing is we have a procedure we do in clinic. It's covered by insurance. It takes about 1 to 2 minutes to do, and we can clear off that membrane, and the vision goes back to what it was right after the surgery. So here, just kind of demonstrating to you, after cataract surgery, we can see the lens here very clear. As the back of that capsule starts to stick to the lens, you can see some haziness. This is where it starts becoming a little visually significant, where patients are like, my vision was more sharp right after the surgery than now. And you can see this is not something we commonly see here in the US, but you can get to the point where it's almost as bad as a cataract. But with this kind of laser here, we can focus on the back of that membrane and clear it. It's not painful. Usually, like I said, takes 1 minute, maybe 2 minutes max. And then you can see here we've cleared the center of that lens, and the vision goes back to what it was. So before we kind of go on to dry eye and how that relates to cataract surgery. Just some conclusions on cataract surgery. It is the most commonly done surgery in the United States, and vision is very quickly achieved, and in most cases better quality vision. It is an elective procedure. There are always risks, but overall risks are very low. Before the lingo was like, oh, your cataract has to be ripe. And I think, in the 80s and the 90s, cataract surgery was still, the risks were high, where now it's at the point where it's getting in the way of your day-to-day activities. We should take care of it. That, to me, is basically when the cataract is ripe. If it's not bothering you, no point to do surgery. But if it's getting in the way of driving or things that you want to do, it makes sense that we do it. And I think the great thing here is that we have technology like laser cataract surgery and intraocular lenses that really kind of allow you to customize what type of vision you want to have after the surgery. And so that's kind of a big thing. And I think, so let's I'm going to share a case and kind of tie this in of where dry eye and how that kind of comes in. So we have a patient that's coming in. She's 76 and she says she wants cataract surgery. Her friend had cataract surgery, doesn't need glasses anymore. She's noticing nighttime driving issues, having difficulty with watching and reading, but she feels like her eyes are fine. They're not painful. So you can see here how much this cataract, is affecting her day to day. We move on to the exam. We can see her overall vision. Her best corrected vision is 20/50 in the right and 20/60 in the left. So kind of basically past borderline driving vision. And we can see with her glare testing, her vision drops by 2 lines in the right and 4 lines in the left, kind of indicating that when she's driving at night, her vision is actually getting much worse. Looking at the surface of her cornea, this is a drop we put in to kind of see the surface of the eye, and you can see this kind of staining here. This is dry eye, and this is not like I didn't put my drops in like this morning. This is chronic dry eye here. You can see kind of that staining, and these little spots in between is kind of the tears evaporating very quickly. And so why do we care about this? Well, we mentioned how, the measurements, getting the measurements accurate for cataract surgery are dependent on the surface of the cornea being regular. This is not a regular surface, so our measurements are not going to be great, and the lens that we go with is going to potentially be affected by this. Not so much of an issue if we're going with a standard lens, but if we're thinking of one of the lifestyle lenses, it's a big deal. The other thing kind of, what we talk about with the eyelids, blepharitis, meibomian gland dysfunction, if you've ever heard of that, but that's looking at these glands that are on the edge of the eyelid. They're typically supposed to make kind of like an oily secretion that keeps our tears from evaporating. You can kind of see that this patient's secretions are very thick, and I'll show you exactly how thick they are in just a moment. And then in terms of her cataract, she's got a moderate cataract. So why do we care about dry eye specifically when it comes to cataract surgery? Because like we talked about, it's going to make the surface irregular, make our measurements not precise, and anytime we're going to be putting a lens in your eye that's going to stay with you for the rest of life, we want our measurements to be spot on. The other thing is the vast majority of us have dry eye. We just don't know it. We're walking around. And then something like cataract surgery, even though we have the dry eye, can throw us over. So it's kind of like the straw on the camel's back, where then after the cataract surgery, then we start noticing the dry eye. But the focus is that we just did a surgery, not on that this has been there for years kind of a thing. And this is something that I see on a daily basis. So it's another important reason of why we need to optimize dry eye before doing any sort of surgery. And just kind of sharing the literature here, 60% of people coming in for a cataract evaluation have no symptoms of dry eye. Of those, half had actual signs of dryness when we're looking at them under the microscope. And overall, if we're talking about any sign of dryness, 80% of our patients that are coming in for cataract surgery have some sort of level of dry eye. We have some further testing that we can do in office looking at inflammatory dry eye. And, patients that are not symptomatic, we did that testing on them, and over half were positive for inflammatory dry eye. So this is real. It's not only just a Southern California thing. It's out there, and this is why it's really important that we optimize this and get this diagnosed before our cataract surgery. So going back to our patient, sharing, hopefully everybody already ate dinner. But just kind of showing you, here's the eyelids and that oil secretion that we're talking about. You're going to see here with just gentle squeezing, it comes out like string cheese. This should be like olive oil consistency coming out. And so you can see the oily component of the tear film in this patient is not coming out. And this is where, if this sits in those oil glands for a long time, it can lead to chalazion and styes. It's just basically those glands get clogged and they kind of swell up. It's from chronic meibomian gland dysfunction. So hopefully you guys believe me, she has dry eye. So what can we do in office to kind of help screen for dry eye? And this is why it's really important that you go to a location that is a dry eye center, because you want to make sure they have the latest, greatest technology. So one thing we can do is look at the osmolarity. And so this is kind of looking at the tear film and seeing, is it too oily? Is it not oily enough? And so you can see with our patient, her osmolarity, normal value should be above 308. With her right eye is fine. And her left eye, though, the osmolarity is off. So telling us that she's got evaporative dry eye, we need to work on kind of the oily part of her tear film. The other thing we can do is MMP9 testing. So this is a specific inflammatory marker on the ocular surface that has been correlated with dry eye inflammation. So if this, it's basically, like a little swab we do, and it comes back either negative or positive. And we know if it's positive, you've got inflammatory dry eye. And so with our patient, she's got both of those, not only osmolarity, but also the inflammatory dry eye. We can also do imaging of the oil glands. So this is an interferometer that's looking at the oil glands of the eyelid after it's been flipped, the lower lid. So this is a normal kind of, these columnar kind of cells are normal oil ducts. We can see in our patient, she has very few remaining oil glands. They're kind of a lot of atrophy, dropout, and kind of dilation. So kind of what you were seeing, that those 6 secretions are causing the natural oil glands to not function and actually atrophy. So when it comes to cataract surgery, we really want to optimize the ocular surface, and we want to do it quickly, because if you're already getting impacted by your cataracts and you want to be able to dry, this is not something we want to spend years on. So when it comes to cataract surgery, we want to hit this pretty aggressively. And so this comes to what options do we have, over-the-counter prescription procedures, and we'll kind of briefly go over all those. We've kind of now have a better understanding of dry eye, and the tear film is actually made up of 3 components. We have a mucus part on the inside, we have an aqueous watery part in the middle, and then we have the oily part on the outside that keeps the tears from evaporating. So everybody's dry eye is going to be different, and we need to diagnose what type of tear film deficiency do they have and target that. And so that's why just throwing over-the-counter artificial tears doesn't work for everybody. And so, we have, if it's just a simple aqueous deficient, just using more frequent lubricating drops can be helpful, but it's not going to solve the problem if it's more severe dry eye. We have an option of serum tears. That's where we use a lab. They take your blood, mix it, remove all the cells, and then just have the plasma and make tears from that. So it's actually coming from your body, and it's as close as possible as what we can get to the natural tears. For kind of meibomian gland dysfunction or blepharitis, kind of the eyelid margin or eyelid disease, we have different options where you can try treatments at home, and then we have in-office treatments to kind of optimize that. When it comes to inflammatory dry eye, we have medications that kind of can target that, things like Restasis and a few other things that we'll discuss. And then there's some other things we can try, like placing punctal plugs. So this is like plumbing. We're just blocking the drainage flow of the tear ducts to kind of keep your tears around longer. We can do therapeutic contact lenses short term to kind of allow the surface of the eye to heal. The other thing is environmental, but this is always the hardest because we're always either reading or on screens. That's when our blink rate goes down and our dryness gets worse. And so we got to look at dry eye as a chronic inflammatory condition, and it's just the dryness leads to inflammation, that leads the dryness to get worse, that leads to vision problems, it's just a cycle. And so we've got to throw a wrench and stop that. And that's actually in the last, I'd say, 5 years, we've finally come to this understanding that it's not just a simple disease that you can treat very, throw like random things at it. So when it comes to inflammatory dry eye, we have topical cyclosporin. Probably you all have heard of Restasis. This was the original form, and so it's a 0.05 concentration. We have Cequa, which is about double that, and then a newer eye drop that we'll talk about, which is called Vivi, which is the strongest and has a combination with something else as well. But with cyclosporin, what we're doing is we're lowering that inflammation on the surface of the eye, so that way the glands will turn on again and start making the tears naturally. Xiidra or lifitegrast is another option. It just works a little bit higher up the pathway, has some kind of sensations of like a metallic taste or blurry vision, so sometimes patients aren't able to tolerate that. And then a short-term trial of steroid eye drops can help too. When it comes to the eyelid, we have treatments you can do at home, like warm compresses and eyelid washes. We can also do a deep clean of the eyelids. Just imagine years of that oil building up, makeup particles, lotions. It causes a lot of clogging. And so this definitely is a deep exfoliation that we can do in office. There's also in-office procedures where we can kind of help clear the oil glands. So these are all different types of thermal treatments where an apparatus kind of hooks up to the eyelid, warms it up, and then does a pressure sequence to get that oil to kind of flow again. The key here is you have to have some meibomian glands left for that to work. People who've had LipiFlow and say it doesn't work, it's because their glands have so atrophied, there's nothing to kind of bring back. So that's why it's important to do the imaging beforehand too. Another thing you've probably heard about when it comes to dry eye is omega-3s. So there's this large study that came out looking at dry eye with patients getting olive oil and omega-3, and they found no difference. And so then everybody was like, just throw the omega-3 in the garbage. It's not doing anything for you. But that study didn't have a control. They didn't compare it to people who weren't getting any sort of supplementation. And the olive oil group was like getting, I think it was like 6 teaspoons of olive oil a day. I'm pretty sure if I had that much, like my skin would be amazing. So there's been some other meta-analysis studies that have come out and found that omega-3 is helpful, especially with getting the oil secretions more oily. So don't give up on omega-3s. We've talked about the serum tears. This is kind of taking the blood and spinning it down. You can see here in the top right, this is kind of the serum, not the cells. That's what's turned into eye drops. Downsides, you have to do a blood draw. It has to go through a special pharmacy. So there are some kind of things that make it a little difficult, but patients have great response and it's a natural option. What's new? So we have this medication called Mibo. So this is PFHO. So this is an actual medication grade lubricant. It lasts much longer than the over-the-counter drop. So active time is like 4 hours. The other thing is it can get in the oil glands and help the secretions to get more liquidy. So it's kind of working on two ends. Vivi, like we talked about, is a higher dose cyclosporin, but it's coupled with that. So you're getting 2 at 1. So it potentially works a little bit better than, just the Restasis on its own. And then Lottler is a new medication that we finally have something to treat Demodex blepharitis. So if you were grossed out before, I'm sorry, it's about to get a little bit more gross, but we all have this microorganism that lives on our skin. It's called Demodex. And what it can do is it can get at the base of the lashes and set up shop and lead to chronic inflammation that causes itching, irritation, and worsening dry eye. And so what that treatment can kind of target that, and I'll show you in a moment what that looks like. But here just kind of demonstrating with Mibo versus over-the-counter artificial tears, the overall, you need a much less amount of this lubricant and it lasts much longer. So much higher quality medication-grade lubricant. And then when it comes to the Demodex, this is what that microorganism looks like when it's alive, and it's all on our skin. When it sets up shop on the eyelids, it kind of looks like that, and this is what it looks like on a microscope. So we finally have a treatment. Before it was just kind of like cleaning the lashes. We couldn't really get it taken care of, but now we can actually target that. I think the take-home thing when it comes to dry eye and cataract surgery is that patient education, because if it's not bothering you, you're not going to realize that it's a problem. And I think the other thing is the more that our patients are aware of what we're treating and what we're trying to accomplish, the more likely we are to stick to the treatment regimen. So now in terms of conclusions for dry eye, hopefully we kind of get the point of why it's important to get the dryness diagnosed first, optimized before cataract surgery. And treating dry eye before cataract surgery is a little bit more aggressive than just coming in for a dry eye evaluation, just because we have that clock ticking, and we're likely going to try 2 or 3 different modalities. Whereas with generic dry eye, we're probably going to try one, see how you do, add another one, see how you do, instead of just throwing the kitchen sink at you. And the last thing for us as ophthalmologists is we don't want to turn our asymptomatic patients who have the dry eye before but are noticing it to a symptomatic patient after the surgery who's upset. So that's kind of the importance here of that. And that's all I have for this evening. And this is our Eye Institute. I welcome you all to come and take a tour. This is Orbis. I don't know if you've ever heard of the Flying Eye Hospital. It's a fully fledged eye hospital that we can fly to different countries and provide eye surgery and training. So opening it up to any questions, discussion, and thank you all
very much.
Again.
I'll be coming around with the microphone.
I speak loudly. So. How long should the dry eye be treated? Like I'm supposed to have surgery in a month, and I do have dry eye. I haven't done any of that.
It depends on the level of the dryness. If it's mild, probably with just basic lubrication, not so much of a big deal. But if it's moderate to severe, that's something I watch my patients serially. So I will have their pre-op measurements. If something doesn't look right and they're dry, I'll treat the dryness, have them come back, repeat the measurements. If I'm seeing changes, then that tells me, okay, we need to put the brakes. Let's try to optimize this a little bit more, and then serially check their measurements again. So kind of using our technology to kind of see how the dryness is also impacting our measurements.
Thank you for the lovely presentation, very informative. I know 2 people, both have had cataract surgery, one probably 25 years ago, one possibly 2 years ago, both of them in the Orange County area. Both of them experience different focus in the eyes, where when they're reading, they have to close an eye in order to read. What causes that, and how is that addressed or fixed?
So I think the question there is I would need more information, because I don't know if they were set for monovision, and so that's why they're closing one eye.
They're both, nothing special. It was just straight
cataract.
Yeah.
The other thing, if there's any sort of pathology in the back of the eye that's affecting their ability to see, they may be preferring the one eye that has the better vision.
Would that be like macular degeneration?
It could be macular degeneration or glaucoma. But yeah, for the most part, that's not a common thing that I hear about, unless it's like kind of intended like monovision, or there's some sort of other pathology, especially because their surgeries are so far apart. I'd be interested to know a little bit more about their eye history.
You haven't seen anything like that?
No, that's not a common complaint that I hear.
Thank you, Dr. Behshad. You kept saying you're going to remove the cataract. You actually removed the whole lens. Is that correct?
Yes, because
Okay.
the lens turns into the cataract. So when we refer to the cataract, we're talking about the pathologic change of the lens.
Okay, so as a child, the muscles inside the eye move the lens for focusing. When you replace the lens with one of your implants, can you still focus with the muscles in the eye?
So that's where, especially with the standard lens, you're only having the one focus. So our lens, when we're a baby or a child, is liquidy. So those muscles can actually change the shape. These lenses, for the most part, are like either silicone or PMMA, so they can't adjust the size. Back, I would say maybe about 10 years ago, there was a lens that was a accommodating lens, but over time kind of lost the ability to accommodate. So we don't currently have an accommodating lens that could utilize those muscles. The other thing that's interesting, that we don't fully understand that loss of accommodation, if it's fully the lens getting harder or it's the muscle getting weaker. So this, depending on what type of a physics, optics person you're talking to, will blame either or. But yeah, so usually there's not much accommodating in the implantable lens.
Thank you.
I've always been under the impression that the cataracts had to be right. They number them 1 through 4, and you wanted it to be 3 or 4. But you're the first person I've heard say, would you take them out if they were only a 1 or 2? Or
I think so. One thing, ripe to me, I don't know. It's hard for me to tell a patient that so that's why maybe I have difficulty using the ripe term. But I think it comes down to symptoms. So if you've got a 2, and the grading scale, depending on which ophthalmologist, optometrist, it's going to be different. But I would say if it's on a scale of 4, if you've got a 2 and a 3 and you're doing okay, I would probably want to watch you closer. Now, if you're a 1.5 and a 2 and you're having symptoms, I think the cataract surgery makes sense. Previously, the risks of cataract surgery were higher, the recovery was much more involved, and the lens implants were not as good. So we were always waiting until the cataract was almost a rock to take it out, so that way all our patients kind of had a big notice or big improvement in their vision.
And typically, how you do both eyes pretty close together? I mean, couldn't you have one eye that was maybe a 2 and another eye that was 4? But it seems like people usually do them pretty close together.
Yeah, I would say most people's cataracts are symmetric, but sometimes one eye is more advanced. And so that's really the patient's call. And a lot of patients will have that eye done. And then, in that week post-op period, they're like, even though they weren't planning on the second eye, they were going to push it off. They're like, no, I want this vision in my other eye. Let's schedule that. And so that's a nice thing for our patients. You can have that, you can make that decision yourself, and you can actually see the vision in the other eye. So it's going to be case by case.
I know you didn't address glaucoma specifically. However, if you have acute angles, as I was told, the doctor did a hole with a laser through. Does that affect having cataract surgery later?
So great question. And you bring up because I'm not a glaucoma specialist, but anytime I do cataract surgery on someone who's got narrow angles or has had, angle closure, actually removing the cataract makes space in the eye, and so it actually can treat the narrow angle or the shallow angle. And so having a previous PI or a laser iridotomy, what you're referring to, doesn't increase the risk of the surgery. But going back to the previous question, if I've got someone with a mild cataract and they have either narrow angles or acute angle glaucoma, the cataract surgery sooner the better.
Would you assume that one lens is going to last for the rest of your life?
Because we've had many of the implant lenses available for decades now, and so for the most part, yes, the lens that we place in your eye is going to expire long after you have expired. That doesn't mean we can't exchange it. As surgeons, we always love to do one surgery and be done. But an option of exchanging a lens is possible. And sometimes we have patients that before the surgery, they want their vision set for distance, and then they're like, I'm okay with reading glasses, but then they realize, no, all I'm doing now is reading. So we have options, for example, to switch it and exchange lenses. But for the most part, yes.
There's someone I know who said he's had 2 cataracts corrected. And he said the first one, which was maybe 5 years before the other one, doesn't seem as clear anymore.
So I think the question is maybe there might be that posterior capsular pacification that kind of slowly develops. The other thing is when you space your eyes out like that, sometimes that same lens, there's a newer model, and so you can potentially have better quality vision in one eye. That's something I wouldn't say 5 years, but usually a 10-year difference might be noticeable.
Yeah, I'm considering the surgery, and the driver is that periodically I see a shift in visual acuity, a little bit of blurriness, I think mostly in distant vision. Other than that, pretty much asymptomatic. So I'm just sort of wondering if you can tell me, well, what are the things that I really should be considering as to whether or not to go ahead?
Yeah, I think for the most part, patients, they know when they're ready because they're like what you're saying, but they're like, I can't see the TV with my glasses and I really want to watch TV, or I can't drive at night. So there's a specific effect to your day-to-day activities. And so I think when that is real and it's happening, cataract surgery makes the most sense.
So it's like, I really should be somewhat annoyed.
I wouldn't say somewhat annoyed, but when you feel like, for example, you're avoiding driving at night, or when it's really bright out, like your vision is affected. I don't know, you play golf and you feel like your golf game is not as good as it was. Things like that. Or like with reading, you have the light on bright, you have your reading glasses and you're having difficult reading. I think those are kind of situations that make sense to do it. But if you're in that kind of situation, you're like, hey, it's a little bothersome, I think just following it closely would be okay.
I have a couple questions. Do you think you'll be seeing it more common to do both eyes at the same time? My ophthalmologist mentioned that the other day, and I was very surprised. And what to consider with that. And secondly, anything to consider if you're not in your 70s or 80s and getting cataract surgery, or what might be the reason that that's happening?
Yeah, so the first question, definitely there are more surgeons who are considering doing both eyes on the same day. Especially, it's a bigger consideration with the light adjustable lens, because that's the lens that, if you remember, that has the adjustments. And so the period after, you've got to wear those protective glasses until it's locked in. And so for a convenience for a lot of patients, they don't want to have that extra week where they're waiting for that second eye to heal. So some surgeons will do both eyes on the same day. I think, as ophthalmologists, we may be a little bit extra paranoid when it comes to that, and that's why historically we weren't doing a lot of same-day surgeries, just because if there's any sort of infection or severe inflammation in the first eye, and we've also done a surgery on the second eye, how does that impact the healing of the other eye? And so those are kind of considerations to think about. I don't think you should feel pressured into doing both eyes on the same day. I have the opposite experience where patients are arm wrestling with me and they're like, can you just do both on the same day? And I'm just like, I don't know, can we just 1 week? So that's that. Now the second question, we talked about other types of cataracts medication side effects. People that are very nearsighted, they can form cataracts sooner than other people. I'm actually amazed that I get a lot of third and fourth opinions of someone in their 40s, and they're like, I've had glasses, contacts, I can't see, and then taking a close look, and I'm like, you've got a cataract, it's significant. And then during the surgery, it's actually much more dense than what I would anticipate for someone else their age. And so I think the what you decide on the lens is going to be the most important, just because you have to kind of envision what you're doing day to day now, what you're going to be doing day to day in 20, 30 years. And so that's where, I think the decision is important on that end. However, if you're okay with wearing glasses and contacts, going with the standard lens is a good option, but looking at it as an opportunity to potentially consider one of the premium lenses to get you out of needing glasses for many of your day-to-day stuff.
Is it, if you prefer a standard lens, can you have a toric standard lens? And then a follow-up question, back in the day, like around the 80s, when someone had cataract surgery, it appeared to me that their eyes had kind of a shimmer to them. Is that still true?
So the cataract actually blocks light getting into the eye. And so when you put a clear lens, you may see a little bit of the light reflecting much more clearly from the lens. But that's actually just the difference of the cataract obstructing the light. But for the most part, newer lenses, not really that noticeable. But I have heard from patients who've had cataract surgery before that they're like, my grandma looked like really strange after her cataract surgery. So that's that. And then in terms of the astigmatism correction, you can get a standard multifocal. All of the lenses now have the astigmatism correction too. Okay. It's just with the standard lens, you have to pay extra for the correction.
What is the success rate of the astigmatism surgery at the time of the cataract surgery, just to follow up?
So I would say if anyone is promising you 100% guarantee that your astigmatism is going to be zero, something's a little bit off there. So my conversation is managing the astigmatism, because that's also why I like to couple the astigmatism lens with the laser, because the astigmatism correction comes in like half diopter steps. And so sometimes people need like 3 1/4. And so that's where doing the astigmatism lens and a little adjustment with the laser can be helpful. And And then the other thing is everybody's eye is going to heal differently. And so sometimes you can get a little bit of overcorrection in the astigmatism that kind of wears off over time. But for the most part, if there's a significant astigmatism, treating it is going to improve your quality of vision. But on the other hand, no one could promise you that it's going to be zero, but as close as possible.
With the light adjusted, you're going to have about a month where you're not really seeing optimally. What do you do when you're driving or to watch anything? Because your vision's going to be very poor, isn't it?
So I can give you a real life example. My father went with the light adjustable lens, and he's a practicing physician. So he actually went back to work like 3 to 4 days after. And his vision, before any adjustments, he was like 20/25. And then he just needed a little bit of magnification, which he was functioning fine. And then after every adjustment, he ended up having 2 adjustments. He went with monovision and then got it locked in. So he was functioning, his vision was usable, but it's like little tweaks to the astigmatism and getting the focal point there, that's kind of where the adjusting is. But I mean, you're day to day for the most part.
Thank you.
The very excellent lecture, appreciated it. Could you just go over what the limitations of type of lenses for people who have had LASIK surgery?
Great question. So this, I could talk for hours.
Just
He's like, you've talked enough and you've showed enough videos. So with LASIK, we're reshaping the surface of the cornea. So the center of the cornea is going to be different than the outer. So you definitely want high definition imaging when it comes time to figuring out the lens power, because with different parts of the corneas being different shapes, it can affect the outcome of the lens that goes in the eye. The light adjustable, hands down, for someone who's had LASIK, is going to be the best option, just because afterwards we can make those minor adjustments, just because it might be a little bit of astigmatism that is needed in someone who's had LASIK. But for the most part, a lot of our calculators have advanced that we now get pretty close, like 95% accuracy. And then we do have technology that we can use in the operating room for people who've had LASIK, where we can do an additional measurement while they're on the table when the cataract's removed to confirm the lens power that's going in their eye. And that can be done with the standard lens option. But if the light adjustable is in your your budget, that would be my highest recommendation. My father had LASIK too, so that's why.
What's the budget?
At UCI, it's packaged with laser, and it's $5,900 per eye. So it's pretty pricey, but you have all the post-op and the adjustments and the quality of vision. It's well worth it if you look at it as an investment.
We're going to have just a couple more questions.
I think you just answered my question. I was looking for a ballpark for some of these premium lenses, but the light adjustable is like about $5,900 per eye.
And you can call around and ask just because, and give me the feedback when you figure it out from the different practices in town. But I can quote you UCI, and sometimes our prices are like super low compared to other places, and sometimes they're kind of like in the same.
Is that UCI's most expensive then, the light adjustable?
Yes.
Okay.
A multifocal is going to run around $3,900, so it's about $2,000 less, but you don't have as much back and forth and adjustments to do with the multifocals. That's why it's a little less.
If a patient has mild cataracts, but a retinal membrane on one eye, how do you deal with those two things? Do you do one first, or does one affect the other?
Yeah, so for the most part, and I think you're referring to an epiretinal membrane, most of those don't affect vision, but they can affect, depending on like the level of the thickness of the membrane. And so that would be a discussion between the cataract surgeon and the retina specialist to kind of decide. So this is kind of where we get together and kind of scratch our head and look at the photos and kind of decide, because the cataract surgery ultimately is going to improve your quality of vision focused on that retina. But if the retina has that membrane that's kind of making things distorted, that's likely going to stay. So
you do the cataract first?
Well, it depends, because if the cataract is mild and it's enough of a view for the retina surgeon to do the membrane peel, that would be kind of the recommended approach if it's significant and it's going to be removed. And then after the eye is healed, then to do the cataract surgery. But sometimes the cataract is obstructing the retina surgeon's view, and so that's why they want it taken care of first.
So they have to discuss it and figure it out.
It's going to be case by case on that too. But it'd be good to have two surgeons that kind of communicate
Okay,
well.
thanks.
All right, this will be our last question.
Should a person get a glaucoma exam and a exam for cataracts, and then how do you decide which one to do first?
So on a basic eye exam, there are risk factors that we can kind of screen for glaucoma. So part of the cataract evaluation, if you've never been told you have glaucoma, there are certain things that can kind of come up that warrant us, okay, we should kind of look into this further to see if you have glaucoma or not. There are glaucoma surgeries that can be done at the same time as cataract surgery. And so that's kind of the importance there to know if you do have glaucoma or not. Some levels of glaucoma are pretty severe that the surgeries that we can do at the same time combined with cataract surgery are not enough. And so that's where a glaucoma specialist would come in handy to kind of make that determination.
Are there businesses and doctors that are quite far behind your institute on the latest technologies?
I would say there are two of the popular combined glaucoma surgeries that are done with cataract surgery all across the US and the United States that actually originated from UCI faculty. If it was my family member, I would definitely consider an evaluation if they had glaucoma at UCI.
In general, is your institute far beyond in technology over independent doctors for cataracts?
So I'm going to answer your question biased, yes, but it's because we're also, there are glaucoma specialists outside of UCI who refer their patients to us to take care of them that they're not comfortable handling. So by far, in terms of technology, access to research, new technology, UCI in this area is going to be the best bet.
So thank you very much,
Thank you
Dr.
so
Behshad.
much.
It's been
Thank you,
so
everybody. Great
illuminating.
questions.
This will be online. You may access this video at our website and on YouTube. And then in October 28th, we will be having osteoarthritis, and we have a slight change in November. We're going to headaches. So please come back. We look forward to seeing you. Stay healthy.